Welcome to QD Clinic. I'm Jack Cush, executive editor of RheumNow.com. QD Clinic is brought to you by RheumNow Live. Great rheumatologists like us go to great meetings like this. You can register at rheumnow.live. A unique thing about this RheumNow Live meeting is that, it's going to be streaming, as you know, as all of ours have been since 2019. And we're going to have pre-learns and post-learns, meaning that when you sign up, you're going to get a learning assignment before the lecture from each of our speakers, so that during the program, our speaker is going to focus on cases and decision-making and sort of building on what they've taught you in the pre-learn assignments. And then after the meeting, you're going to get a post-learning assignment, or at least materials, from our speakers as well. It's sort of a unique way. We get you before, during, and after, so as to enrich the quality of the engagement. That's RheumNow Live. Our case today, Rhabdo or not, 26-year-old gal with a history of dermatomyositis. Seen her a few times. Haven't actually seen her in the clinic. It's all been during COVID. Had 2 prior visits where I was introduced to the patient. She was on medicine. I saw her again after her labs were done. She had a CPK that was elevated, 700 or 800, 900, something like that, and was taking methotrexate, and that's about it. I said, let's do this and that, and we'll come back. And this time she comes back, and her labs show that she has a CPK of 22,000. Her aldolase is normal at 4.3. She has no symptoms. She's a little weak, but it only shows up when she's trying to get out of the car or out of a stoop position. Otherwise, she can comb her hair and climb stairs, and she's not short of breath, and her skin is not abnormal in any way. She says she feels fine. She says she's taking her medicine. Wait, maybe she missed methotrexate last week, but really she's doing fine. But the CPK is 22,000. I'm worried. We admit her to the hospital. Could this be rhabdo or not? Rhabdomyolysis, as you know, is a complication of inflammatory muscle diseases. It means basically that you have extreme amounts of muscle damage with release of macromolecules from the myocyte, including myoglobin, which when it gets excreted in the urine turns your urine tea-colored. But all that myoglobin in the urine is bad news for the kidney because it can induce kidney damage and ATN. So she did not have myoglobinuria. She did not have tea-colored urine. Her renal function is normal. Her CK is 22,000. Her aldolase is normal. Her AST is 600. Actually, her AST is 1,000. Her ALT is 900. And why did this happen? Well, we really don't know. It could be noncompliance. It could be there was an intercurrent problem. When you look at extreme elevations of CPK, enough to give you rhabdo, what are the causes? Well, how much is enough to get rhabdo? It's unlikely at levels less than 10,000, but it could occur. When you start looking at 15 and 20,000, rhabdo occurs. When you start looking at more than 20 or 30,000, rhabdo is likely to occur. So luckily, it did not occur in this patient. We got the patient early. We hydrated her, stabilized her, and sent her home. The question is, why, again, does the CPK occur? When you see extreme elevations of CPK, you have to think of a few things. Trauma, crush injuries. I had a case of rhabdo with a CPK of 18,000. Patient was using IV cocaine, was out of his mind on IV cocaine, got rhabdo so bad that he couldn't walk, so he had to roll down the street. That's right, log roll to get mobile, which induced more muscle trauma. He went into rhabdo and really almost lost his kidneys. That was 30 years ago. But trauma. Also, as I just said, cocaine. Bad drugs, especially cocaine, amphetamines, heroin, are notorious for causing muscle damage by causing vasculitis and tissue ischemia. So severe tissue anoxia of any cause. It can happen with inflammatory myositis that's not controlled. It is also very likely with other drugs that are known to be myotoxic, like statins. It's a very, very low risk, but it does happen with statins and other myotoxic drugs. And then infections. Infectious myopathies can often cause a lot of damage and lead to extreme CK elevation with rhabdo risk. Now, what about this case? CK, very, very high, normal aldolase. Actually, that's not uncommon. Doesn't change the diagnosis one beat. What about the converse? Extreme elevation of aldolase with a normal CK. That's less common, but also could be myositis and any one of the causes I just sedated. But when you see very high aldolase and normal CK, should you be thinking myositis? No. You should be thinking liver disease because aldolase comes from liver. You could also be thinking Still's disease and autoinflammatory disease because that's often the aldolase level comes from extreme liver activity seen with the autoinflammatory syndromes as well. Lastly, what do you do about treatment in someone like this? Hydration, IV steroids, get control of the situation. Should she be on methotrexate? Yes, but more. She wasn't on enough. So she went to oral split dose, 20, 25 milligrams a week. I added leflunomide, 20 milligrams once a day. I personally like the combination of methotrexate and leflunomide in difficult to manage inflammatory myositis patients. You could use other drugs, including azathioprine, many people use, obviously methotrexate, and even drugs like cyclosporin or tacrolimus can be helpful here. Biologics, we don't really know of a really good biologic in this situation. Anyway, a really good case. She's doing really well. She's on high-dose steroids, and I'm invoking the Ziffism. Dr. Morris Ziff, one of my mentors, said acute, uncontrolled, inflammatory polymyositis, dermatomyositis, 80 milligrams a day of steroids. That's what she's on. Bye.